nonpartisan research, policy, and community power building organization focused on providing innovative solutions that address important clinical, research, and policy issues in Medicaid through multi-stakeholder engagement, research, data analysis, education, quality improvement initiatives, and dissemination and implementation activities. Our mission is to improve the lives of Medicaid members through the development, implementation, and dissemination of innovative evidence-based practices and models of care that promote quality, value, equity, and the engagement of patients, families, and communities. As we say at IMI, it's not the statistics that make Medicaid real, it's when you love one of those numbers. And as a former Medicaid member myself, I understand how important this program is to individuals, families, and communities. Everyone covered by Medicaid is much more than just a number. That's what we're here to discuss today. We're going to go beyond those numbers that are in our survey results and tie the results of the findings back to how it affects the lives of Medicaid members, caregivers, families, and communities. There's a lot of fascinating findings and insights to share. Of course, we're not going to be able to hit all of them, and that's why we'll share with you the fact sheet so that you can dig into those details. But I look forward, most importantly, during our release event, is to hear from the opinions of our esteemed reacting panel members. It's always the highlight of this event. But first, I'd like to thank those who are responsible for making all of this happen. First, the Robert Wood Johnson Foundation for its generous 7-year support of this critical work. Our survey subcommittee and our chair, Poppy Coleman, who you'll hear from later, and the IMI survey team, Sydney Berry, Dr. Gloria Eldridge, and Sarah Holbert. Without all of you, this would not be possible. And I am so delighted and honored that we have Dr. Simbo Ige here with us today to provide opening remarks. Dr. Ige is the Managing Director of Program Healthcare and Public Health System Transformation at the Robert Wood Johnson Foundation. Dr. Ige, the floor is yours.
Hello, everyone, and congratulations to you, IMI, for another year of the MCO survey. I bring you greetings, everyone, from the Robert Wood Johnson Foundation leadership. I am the Managing Director of Programs, and I represent the largest philanthropic organization in the United States that's fully committed, solely committed to improving the health of Americans. So at the foundation, we have one core question, which is how can we make our country a healthy place to live, work, and play for everyone? One of the answers we have found to that question is that we need to have excellent health systems, including the systems that promote health, the systems that preserve health, the systems that restore health, and the systems that provide healthcare. But there's still many questions that need answers. And there are also many answers we have that need action. Our partnership with IMI means that there are more answers to the questions that we have, and that most key actors in our health system can understand what is working well and where things can be improved. But we also want to acknowledge that over this last 7 years of the MCO surveys, we have seen many answers that need action and actions that need to be sustained. Last year, Karen Dale asked, what must you believe to take action? I believe that government-funded healthcare, including Medicaid, can be a gold standard of excellence and equity. But it is a team sport. We need all hands on deck to make that a reality. So my call to you all today is for us to identify the answers to the questions, but also to act on the answers that we have. At the foundation, we remain committed to partnership with those who are working to make our health system equitable and accountable. And we are very excited that the MCO survey is available for us all to guide our actions. Thank you, Jennifer. Thank you, everyone who's made this survey happen. And thank you, everyone who's joined us for our conversation today.
Thank you. Really appreciate those remarks. And thank you for raising up the comments from Karen Dale. Always an inspiration and pushing us in innovative ways. So let's dig into the work before us. There we go, next slide. Since our beginning 8 years ago, IMA's focus on delivering unbiased data to support improvement of the Medicaid program and the health of the nation. And we have developed this really broad portfolio of work addressing critically important issues in Medicaid. Everything from maternal health, redetermination, social determinants of health, value-based purchasing, and Medicaid risk management. The MCO survey is our flagship project, but it's just one among many, some of which we will reference here today. So our one-of-a-kind survey shows longitudinal findings and trends among Medicaid health plans over the last 7 years. And our understanding of the data has evolved, as Dr. Ige had mentioned, over the years as we collect information. But we've also expanded our understanding through the collection of Medicaid MCO best practices and analyzing the data for trends. And as a reminder, as we go through some of the detailed findings from the survey results this year, we ask that you use the Q&A feature to send any questions you may have. And we will definitely get to those and have the panel provide answers later in this presentation. So let's dig in. Unique to this year is our National Medicaid Redetermination Survey. It captures both the challenges experienced by and the innovations led by Medicaid health plans. We launched this additional 4-part redetermination survey, originally fielded in May of this year, and then again in August. We'll continue to field this survey early next year and in the spring, completing this series. And we have to thank, once again, Robert Wood Johnson Foundation for their support of the redetermination survey also. We will discuss some of the results from these surveys today, and we ask you to stay tuned for the results of the next redetermination survey. So kicking off our findings from the annual Medicaid MCO survey, as you may recall, it captures information from 11 core domains, ranging from behavioral health and child and adolescent health to telehealth and value-based purchasing. These are our core domains for our annual survey. The supplemental redetermination survey captures data around enrollment, disenrollment, barriers, flexibilities, and innovations we're seeing in Medicaid right now. There are multiple trends, insights, and data points to be analyzed from both surveys. But when we looked at the data, we really coalesced around several key findings. And it's those key findings that I'm going to share with you today. But again, there's so much more, and encourage you to check out those fact sheets so that you can dig in even deeper. The completed surveys we received, and just as some background, the completed surveys we received represent 31 of the 41 states with Medicaid managed care. You've got great representation across the United States. With the health plans responding to the survey, they're proportionate to the different types of health plans nationally, with private nonprofit, private for-profit, government-funded, multi-state, single-state, and various membership sizes. Aligned with the national demographic data, the majority of respondents are health plans representing private, nonprofit, single-state, with a range of sizes. So I promise, let's dive in now. So Medicaid health plans saw an increase in covered services for pregnant people in 2023 when compared to just 2 years ago. Some key data points to note include changes in nutritional counseling over the years at 83%, up from 62%, support from a community health worker at 83%, up from 52%, lactation counseling at 75%, up from 52%, and support from a doula at 65%, up from 38%. With the interest in doula services, we can anticipate for next year that the survey data will continue to rise. We also saw expanded coverage of education and community-based services, including childbirth, breastfeeding, and parent classes. So consistent amongst all the domains of the survey, data sharing continues to be a challenge. For maternal and perinatal health, health plans noted several data sharing pipelines that state Medicaid agencies could support, including between the state and health plans and provider groups, and health plans and community-based organizations. In addition to the maternal health crisis, the survey findings highlighted barriers when it comes to child and adolescent health. The majority of Medicaid health plans express barriers in 8 of the 14 areas surveyed, including challenges with coordinating with schools, churn, and unmet social needs. In the bar charts on the left hand of the slide, it's apparent that these issues are consistent across all health plans, regardless of size. The emergence of COVID-19 shed an increased light on the importance of child and adolescent behavioral health services. Barriers in this space are varied, but the top issues are all workforce related, such as availability of providers, wait times, and access to in-person services. Secondary issues that we saw on the data included access to telehealth, availability of treatment options for substance use disorder, pediatrician capacity, and again, coordinating with schools. However, I believe that the identification of barriers, and I say this all the time, really truly serves as a roadmap for opportunities to advance innovation. So returning back to the overall population of individuals enrolled in Medicaid, there are a wide range of factors that limit or impact Medicaid members' access to care. And as we know, coverage does not mean access. So as you can see from the slide, Medicaid health plans noted that their members' needs are not being met at 92%, and there is a persistent lack of social supports at 71%. Workforce challenges, again, continue to persist, with 85% of Medicaid health plans facing barriers related to the direct care workforce. And redetermination is on everybody's mind, and it certainly has been compounding these challenges. However, the most recent findings from the redetermination survey identified ways that state agencies can help. And no surprise, and this is going to be a theme through all of the fact sheets that you review from the survey findings this year, that data sharing tops the list as one of the greatest areas that they would like to have support, especially from state agency staff. But we do know that there's also an increased need for state agency staff capacity and resources to support outreach. One major trend that has persisted since COVID-19 is the uptake of telehealth as a modality to increase access. Medicaid health plans saw improved outcomes as a result. So 75%, as you can see, of health plans said telehealth improved access to services, with 50% noting an increase for those seeking behavioral health. That was a huge gap area before the pandemic and the increased flexibilities that the public health emergency afforded us. And nearly half of health plans, at 46%, reported that they're connecting their members to community-based organizations to increase access to internet and technology services. This is really, truly important. Policies, as I said, that were implemented during the pandemic truly increase these flexibilities and are allowing us to see these results today. Medicaid health plans also share that there is an opportunity to continue working on telehealth policy changes that could further help to improve access. And some of them included school-based behavioral health services and evidence-based remote patient monitoring. As we continue to see with the release of new guidance, CMS is committed to transitioning providers in the US into value-based healthcare. We also know that clinical practices are struggling to make that transition. Our survey reflects that reality. So Medicaid health plans share that they're continuing to experience challenges with provider willingness to adopt alternative payment models. And as we all know, the challenges of taking on both upside and downside risks persist. When the survey first fielded in 2017, the biggest barrier faced in this area for health plans was the uncertain and shifting policy requirements. Today, as you'll see from the results, it's less of a concern, which is the beauty of having a longitudinal survey, is being able to see those changes. Our last data point before I hand it over to our esteemed panel is really focused on algorithm bias and its impact on health equity. As artificial intelligence and decision-making algorithms are used to improve efficiencies and decrease costs, it also has the potential to do harm. Of our survey respondents, 42% indicated that they check for bias in their algorithms. And of those, 34% of them have changed or eliminated them upon finding it. We anticipate that these percentages will increase over time also. So sort of in closing here, the findings presented today represent a very small proportion of the information that's available. And my colleagues are going to share the link to all the fact sheets on the 11 domains of the annual Medicaid MCO survey, plus the most recent redetermination survey findings. We certainly hope that this survey will serve as a jumping off point for informed discussions among health plans, policymakers, community groups, clinicians, and the general public about how we can strengthen, as Dr. Ige had mentioned, and improve Medicaid program, enhance the lives of Medicaid members, and spur healthcare innovation more broadly. As I shared earlier, this data serves as the roadmap towards innovation. Now, I'm really excited to hand it off to our moderator to get some reactions from our esteemed panel of experts. So first, I'm very pleased to introduce Gail Graham, who will moderate our panel. Gail is the director of Mount Lebanon Baptist Church HIV/AIDS Ministry Outreach Services and a commissioner on the Baltimore City HIV Planning Group. Gail is an advocate for community-informed Medicaid improvements that reflect the needs of community members and is currently serving as secretary of IMI's governing board. You can learn more about Gail and all the panelists at the link in the chat. So Gail, I'm going to hand it over to you.
Thank you, Jennifer. Welcome, everyone. It is my honor to introduce you to our esteemed panelists. Lindsay Browning is the Director of Medicaid Programming at the National Association of Medicaid Directors. In that role, she leads the association's work to support shared learning across the 56 states and territories around key challenges and opportunities facing Medicaid leaders. Poppy Coleman manages encounter data submissions for the UPC Health Plan Medicaid, LTSS, and CHIP lines of business. She also leads the survey subcommittee of IMI, which provides direction and oversight for the annual survey project team. And finally, but certainly not least, Dr. Nina Everett is the Chief Medical Officer of Priority Partners Managed Care Organization of Johns Hopkins Health Plan. She is an internist by training who has worked in federally qualified community health centers before her work for Medicaid health plan, and is passionate about the care of under-resourced people and communities. Welcome, ladies. My first question to the panel is, did anything surprise you about the survey result? Was there anything that you did not expect? Let's start with Poppy.
Hi, Gail. Thanks so much for the question. What a great opportunity to respond to all this amazing data. So Jennifer stole my thunder just a little bit because my big surprise was that that longitudinal trend that we saw for providers not being as willing, or the major barrier to adoption of value-based purchasing models being provider willingness to participate. And, I thought it was really interesting to see that in 2017, when that survey first asked that question, everything was kind of oh, everything's a barrier. This is kind of a lot to take on. But over time, even Medicaid payment rates, which are, of course, notoriously lower than commercial, that has gone down as a response for Medicaid MCOs as a barrier. And even the shifting landscape, I think it's not shifting as much. It's consistently being seen as a priority for states and federal regulators of Medicaid, that there's more push to these value-based programs. However, there is still that provider difficulty to get on board. And I think this is especially interesting when we consider that another data point you'll see in the fact sheets is that less than half of our plans that responded are using downside risk. So there's not even downside on the table for these providers, and still there's some kind of barrier, difficulty getting on board. So thanks.
Thank you. Lindsay?
Yeah, I would just build on what Poppy shared, and then add one more thing. I was struck by the challenge around provider willingness to engage in VBP too, and really caught my eye, sort of the notion that the health plans are looking for their state partners to open up some new policy and fiscal levers to shift that perspective. And as an organization that works with state Medicaid policymakers, I was really fascinated by that, and hope there can be some more conversation to explore what some of those opportunities might be. The other big thing that caught my eye or surprised me from the survey results was really this tension, I think, that starts to show up between in the behavioral health space and making behavioral health services accessible. We see a lot of focus and push on increasing the availability of those services via telehealth, but also a challenge of getting of provider availability to deliver in-person services. And I think probably this is a shift in the market and how behavioral health providers are choosing to deliver services, but really a new emerging challenge of how do we make sure services are available in different modalities for people who may prefer them in those modalities, or may only be able to access them in the in-person modality, for example. So just really a challenge that I think plans and policymakers, state policymakers are going to have to work together to address.
Thank you. Dr. Nina?
All right, there you go. There was so much good stuff in the survey, and I have to thank the IMI for putting together such a comprehensive survey. One of the things that surprised me in a good way, actually, were the number of MCOs that looked at member experience when evaluating the effectiveness of their high-risk care coordination. Obviously, everybody has a bottom line, and plans have to make fiscal sense, but it's also the recognition that it's more than that. And so I was very pleased to see that we're looking at how the patient experiences it, because hopefully that means we're moving to a model where our members are the center of what we do. And then the other thing, Dr. Moore actually mentioned it in her earlier statistics, with that even though the use of doulas has increased, the numbers are still low. It looked like about 2/3 of the health plans do provide that benefit, but that means that 1/3 of our birthing population doesn't have access to something that we know there's evidence that shows the outcomes are better, lower C-section rates, low birth rate babies, and then just overall maternal well-being. So we need to do better about that and increase that. Thank you.
Thank you. Can you tell us what you think are the main findings and takeaways from where you sit as Program Director of an Association for State Medicaid Directors, a Senior Manager of Encounters at a large Medicaid health plan, and the Chief Medical Officer at a large Medicaid MCO?
So I guess I'll go first on that. I think the big thing for me, and this wasn't too surprising, but a big takeaway from the work that I do, or for the work that I do, just the pervasive challenges around workforce, provider workforce, and provider capacity. You know, I think Jennifer pointed out the data point that 85% of plans are facing barriers related to the direct care workforce. And we see sort of that concern pop up, the workforce concern pop up a number of places throughout the survey findings. And I really do think this is an existential threat for the Medicaid program and for our healthcare system broadly. And how do we ensure access to care? It was really cool to see in the survey findings, though, some of the creative ways that health plan partners and policymakers are trying to pursue to take on those challenges. You know, partnering with new and non-traditional provider types to deliver care, like community health workers, looking at technology like remote patient monitoring to expand our reach, looking at new settings of care like schools. So I think a lot more work and opportunity in that area. The other thing that was really helpful for me and kind of where I sit at the National Association of Medicaid Directors was to see the theme around data and data sharing throughout the survey, that plans continue to see that as a key barrier to being able to deliver on the objectives of the Medicaid program, and that there are really opportunities to strengthen that flow of data between plans and states, but really also across parts of state government. And how do we think about connecting the data that we have across programs that all serve the Medicaid membership? So those were the two that stuck out to me.
Okay, I can go next. So yes, I work in Encounter Data, which is sending all of our claims data to the state for all of our services that our members utilize. So I'm all about data, and I think that's a big takeaway from every single one of these sections. You know, a lot of MCOs stated that improving data quality, improving data transfer would be key to removing barriers to things. And it's just really interesting. You can think about the form that you might fill out when you're trying to qualify for Medicaid, and there might be a lot of stuff that you put on it, but where does that go? You know, and then if it's received by the state, does it make it to the MCO? Is the MCO actually pulling it and putting it where analysts and, you know, the people who care about it can use it? And then are we giving it to the providers so that they can have patient-centered conscious care. You know, if you don't know who's walking into your office, you don't know how to give them the care that they might need or require. But if they never report it to begin with, it doesn't get anywhere, right? So I think all of this makes me very alert to data flows and kind of just unblocking all the pipes, making sure it all gets where it needs to go. And I think that can be like a push that happens across all of our parts of the organization and the parts of delivering Medicaid. And then I just also wanted to piggyback off what Lindsay said about provider workforce. I think that is, you know, a universal thing that's been kind of something we've been struggling with. And to me, the places that really caught my eye in these fact sheets were those areas where we have a lot of initiatives happening, you know, around reproductive health, around perinatal care. You know, if we have provider workforce issues where we're trying to make changes, it only makes it more and more difficult. And so I think on the Medicaid MCO side, our plans want to be able to provide more. There's demand among our membership, but if that workforce isn't there, it's just unmet demand. So I think that is a through line across all of these sections as well.
That's Nina.
All right, let me get myself off of mute. Actually, one of the big takeaways is, boy, do we have work to do, because one of the questions was around the ability to contact members, and 100% of the plan said that that was a barrier. And so again, if you have something that people want, they will find you. So if they're not finding us, if we have large numbers of unengaged people, then we have to think about how to reimagine what we're marketing in terms of health. And we have to be more broad in that design and give people what they want and not what we think they should have. So that was the first one. And then the other one really highlights what Poppy said about information. And the question that really struck me were the low numbers of health plans that get data on gender identity, sexual orientation, and preferred pronouns. And we certainly know that people in the LGBTQ community are more likely to live below poverty. And that means they are our members. And we have to think about what their needs are, how to address them respectfully. And so there's certainly a lot of work to do in that space, and something that we all need to think about how to do better.
Thank you. Now, we just got finished talking about what Poppy did about the reliance on data. So with the increased reliance on data and artificial intelligence, how can we make sure that data and algorithms address racial disparities and do not make them worse through built-in bias? So Poppy, let's start with you with this question.
Sure. I think this is a brand new frontier for a lot of us. You know, I think it's a lot to realize that algorithms are, you know, trained on existing data, and then we're using them and AI to kind of move into the future and predict things and predict what we might see. So I don't know that I have an answer other than an intentional approach, including developing standards around what it means to use all of our different demographic data that we're interested in. With this focus on health equity, you know, we have a chance to kind of move the needle for underrepresented and underserved communities. That's a big push that we're seeing in this current year and obviously into the future. But as we do that, I think we need to be sure to use data correctly. And so I think developing standards, distributing them to those who use data is a great idea. And then also developing methods to test algorithms for bias. I think this is already happening in the data science kind of world, but I think it can only be improved. And I think it needs to also happen in a way that can be translated to the layperson, to the people who are, you know, just finding data on the internet and trying to interpret it, or even folks at a health plan that may not be trained data scientists. You know, we need to get some tools that are simple and easy to understand so that we can test our own algorithms or our own ways of analysis.
Thank you. Lindsay?
Yeah, I will fully admit that I am a policy wonk by training and not a data expert. But, you know, we do see a lot of focus in Medicaid programs right now and with health plans of how do we have more meaningful member engagement throughout the policymaking, policy implementation process. And I think there may be an opportunity with new AI tools and others to really have individuals who are served by the program at the table from the get-go and double checking our work, double checking some of these pressure tests for bias. So that would be the big thing I would point out. And then I think a continued focus on having diverse teams of leaders working to design and implement these solutions as well, so that biases can be identified throughout.
Thank you. Dr. Nina?
I think one of the important things is that AI is based on someone's intelligence. And so we need to have people with the lived experience of the population that we're serving be involved in that. So that goes to initially health plan staff. When we look with our health equity lens, it's looking externally at the members we serve, but internally at the diversity of our staff, making sure that it represents all experiences. And then the other part of that, which has come up before, is workforce development. As we are out there in our communities, we need to make sure that the schools are good, or they're doing what they're supposed to do in providing training. So I think that's one thing. I know that again, I don't know a lot about AI, so I had to look it up, and I'm learning as we go, but I was pleased that the National AI Initiative Act actually has advancing the trustworthiness of AI as one of the pillars. And I think that we have to be very deliberate in that space. I think AI is good for analyzing data, helping us do better mine it, to do some predictive analysis. But also we all have to remember that as we use it as a time saving and perhaps a dollar saving tool, that it doesn't replace the work we do with members. And what AI lacks is an empathic touch. And so we have to remember that as we use it, that we have to balance its use with the people skills that AI can never replace.
Exactly. What are Medicaid health plans and community-based organizations doing to expand telehealth while ensuring that disparities are not exacerbated? Lindsay, let's start with you.
Yeah, and again, from where I sit and sort of working with state policymakers, I see a lot of effort for state policymakers to work with their plan partners to think about how do we link members to other supports that can enable telehealth access. So, for example, other federal efforts around broadband access. How can health plan partners and policymakers play a role in linking members to those supports, or supports that may make phones or computers accessible to folks? So I think that's one strategy. I think the other thing from my perspective is making sure that telehealth aligns with member preference. Goes back to the point I made at the beginning of if folks want to be able to receive in-person services, having an option for that. If they want to be able to do virtual services, having the means and the tools and the accessibility for that is equally important. And then finally, I would say it's really important to ensure we continue to assess the quality of care being delivered through telehealth. I've heard particular concerns around individuals with limited English proficiency, and making sure that they're getting as high quality of an experience of care through the telehealth modality as they would through an in-person modality. So just a couple of thoughts there.
Thank you. Dr. Nina?
Okay. What Lindsay said in terms of broadband access, so that's a big one. The other thing is that we have to recognize that in the same way that there's a science to an in-person visit, there's a science to a telehealth visit. And I think we have to begin to explore that so that we can train providers to use what we know works in that interaction. I think that COVID caused us to do a 360 in making it available, something that probably would not have happened this quickly. I think that there's certainly value in rural areas and in the BH space, because I think that that's where it's really used, but we need to not rest on those laurels. And instead we need to press, because as was mentioned, people deserve in-person care when possible. I think we need to embrace the audio only, recognizing that for some members it's intimidating, or they may not have the broadband access, but it definitely has a place, but it shouldn't replace what should happen in person as well.
Thank you. Now we want to open the floor to the audience questions. As a reminder, please submit your questions via the Zoom Q&A function. To kick us off, we received the following question. I don't work for a Medicaid health plan or a state Medicaid agency. I work for a community-based organization. What can I do with the data to help increase and improve care for members? Dr. Everett, do you want to take this one first?
Yep, I can jump in. So actually, one doesn't have to work for a big agency. If one is a community member, they have a voice, they are advocates. And certainly in that space, we need to make sure that people vote. Certainly local races are equally as important as national ones. I know our health plan has a community advisory board, which is for members and the people who are connected to them. So there's always an opportunity to have a voice. And then there are people who work with community-based organizations. We want to partner, we want to listen, we want to hear, we want to use the experience that you have in the community. So there's certainly a role for everyone to play in improving access and improving how we serve our members.
Thank you. Poppy?
So I'm going to go back to data. I think there's sometimes this hesitance to provide personal data, including demographic data, language preference among different communities for so many different reasons. But if a health plan isn't aware of who you are and what your needs are, they can't meet you there. So I think it's, if you're a member or you're trying to become a member, I think it's really important to let people know who you are. Don't be afraid to represent yourself. And then if you're working to advocate for a group or a community, encourage people to be complete in their filling out of data. Our missing data is going to mean you're missing in our outreach efforts and our efforts. So I think that's one of the most important ways to get involved.
Very important. Thank you. Lindsay?
Yeah, I would just wrap around Dr. Everett and Poppy's comments by saying that I think this data helps show how important health plans are as partners to community-based organizations, to providers and others in advancing some of these really important population health issues, healthcare access issues, and would encourage you to use the data, bring it back to your conversations with your partners in the state, engage with your health plan partners, and again, really be active in bringing your voice to the work that's happening in the Medicaid policy space.
Thank you. There's a growing, there's a growing awareness of the gaps in services for children with behavioral health needs. The data indicates that health plans are working in this space, but more needs to be done. What do you see as opportunities to advance innovation in this space? Lindsay, let's start with you.
Yeah, this is such a good question. And we know that the Medicaid unwind has been top priority for Medicaid leaders, in this hothouse year, but behavioral health issues are right behind it as a top challenge, particularly children and youth behavioral health. I think we have sort of two opportunities in this space. We have an opportunity to get upstream and build the community-based structures and systems and support to really prevent crises from emerging. And that's things like, the 988 crisis line and mobile crisis services. How do we bring a child-specific lens to that work? It's things like school-based services. How do we provide care and meet kids where they are and receive services? So sort of the getting upstream. And then the other piece of it is really the acute challenge that I know many health plans and Medicaid agency leaders are facing right now around kids with the most complex behavioral health needs. And how do we find a safe place to care for those kids, to support those kids, and again, wrap around them with caregiver support and other support. So if they do end up in an inpatient setting, an institutional setting, we can get them back into the community as quickly and safely as possible. So just a few thoughts there.
And this one is really near and dear to my heart as a grandmother who took care of a teenage son who was going through some behavioral issues. And we had problems with getting health, in the school system. So this question means a lot. Poppy, what do you think?
Yeah, I think just what Lindsay said, I think innovating around location of care, where can we deliver care? Where can we meet someone with care. And then what are the billable services? You know, I think that there's space to expand provider types alongside, you know, improving the actual number of people in the workforce. I think we should be thinking broader about where can people access that point of care.
Thank you, Dr. Nina. Thank you.
Yeah, I agree. We certainly can work to destigmatize behavioral health and make it part of a normal conversation, which involves training primary care providers to ask about it. And that whole notion of where it's located, because it's sort of one body. So you have to take care of the hair down one place and then the behavioral health somewhere else, sort of suggests that we're split people. And so how can we promote models that have behavioral health embedded in primary care, especially for children, and the notion about bringing that to the schools where children are, making it easy to facilitate that care. Because we have to start with our children and we have to address their needs, because they just grow up to be adults that have more needs that make them hard for us to find them. And so I think if we are more deliberate about that, then we can do better.
Thank you. The survey shows us that there is an increased efforts to ensure access to community-based maternity care services, such as centering pregnancy, doulas, and midwifery-led care. The data shows the utilization is increasing, but there are still barriers. What do you think it will take to remove all barriers to ensure that individuals enrolled in Medicaid have access and coverage to this high-value evidence-based care? Poppy, let's start with you.
Sure. So I think this is another place where there may or may not be uniformity across the country in the types of providers that can be paid by Medicaid. So, you know, I often wonder what's hiding behind our numbers in the survey. You know, we mentioned 76 or 67% of plans can use doulas for their members. Is that because there are state-based preventions from considering a doula an actual provider? Is there some other mechanism that's kind of hiding underneath these things? And so I think as we're identifying, you know, excellence and best practices of care, let's make sure that those things are disseminated across the country and that all Medicaid state regulations match up with it. And I think that that's a lot of the place where barriers are lurking and we're not really even aware of it. So I think expanding what is reimbursable by Medicaid, big deal right there. I think that would help us at least all get on the same playing field with what we consider to be these best practices.
Thank you. Dr. Nina?
You ask a question that keeps me up at night because I think we know these programs work, but the challenge, I mean, there are a myriad of challenges. Certainly one is workforce development and having enough providers that have the appropriate credentials and that can navigate the system so that they can be set up so that they can bill Medicaid. And that's a whole piece that we have to think a little more about. I think if we can find doulas and people in the community who are doing it, they can perhaps do the recruitment for us, because those are faces that our members trust. So if we could increase their numbers so that they're working in their communities, they can do the work for us. And then that's a win-win for everybody. But it's certainly something that we have to continue to think about.
And I would just build on that a little bit of, you know, I think there certainly are, you know, policy choices and barriers in this space, but I think I've seen a lot of states have challenges in building the provider capacity, even when those policy barriers are removed. So training and recruiting providers and creating the demand for the new provider type or the new service as well, and really seeing it take intentional effort and multi-year effort to really do that and make it accessible.
Thank you. Now, there's a lot
Sorry, Gail, can I just add one more thing? Because I think this applies to doulas, but all of the community workers that we think we need to engage with, because I think we are recognizing the value and states recognize the value of us partnering with the community, but can we be more intentional about providing them the support they need? So it's not just the doulas who need to know how to interact with Medicaid, but it's the community health workers, it's the folks in the health advocates in the barbershops. All of them can be our partners, but don't know how, haven't been trained, haven't had a need. So can we be deliberate about maybe creating offices or appointments who will do the work for them and then who can do the billing, who can do all of that stuff, because I think we will be much more successful in that model.
That's a great idea. Thank you. There's a lot of conversation about upside and downside risk and providers being hesitant to enter into VBP initiatives. From your perspective, what can health plans and state Medicaid agencies do to support greater adoption? Lindsay, let's start with you. And first, can you explain what VBP initiatives are?
Absolutely. So VBP initiatives are value-based purchasing initiatives. And broadly, that's a term that describes trying to align healthcare payment to plans and to providers with delivering services that improve quality and contain costs, reduce unnecessary utilization, that sort of thing. So kind of a broad umbrella term. What can be done to support greater adoption? I'm going to get up on a little bit of a soapbox here and say that I think multi-payer alignment is really key in this space. Commercial payers coming alongside, Medicare coming alongside, and really trying to align what we're trying to achieve and what these payment mechanisms are, so that we don't drive providers crazy with trying to participate in 15 different initiatives and report 300 different quality measures and have their payment tied to, dozens or more quality measures. I think it makes it really hard to create that willingness if there's not alignment. I think the other thing probably is streamlining and administrative simplification so that it is simpler and easier for providers to participate in these types of arrangements.
Thank you. Poppy?
Yeah, I think this is actually one of our questions, is like, what would it take to help remove these barriers? And I think Lindsay hit on a couple of them, but I think another one is just education to providers. So this has been an initiative from the state and federal level for a very long time, and all the MCOs are hearing about it. It's in our contracts. It's like, we hear about it a lot. We have to report on it, all this stuff. But I don't know that it's been communicated as strongly, firmly, directly, I don't know, to providers. So like, if there's a lack of provider uptake, perhaps there's a lack of provider understanding that this is a national goal. And so I feel like there's something missing there. I also wonder, this is all to incentivize quality care, but I'm wondering if there needs to be some providers brought to the table to explain why they are hesitant or why they have issues. I know a lot of providers in the different meetings with their MCO partner might express their concerns, but that's at the MCO level. And I think that voice needs to get all the way up to the state and federal level that's setting these policies and setting these goals for the Medicaid MCOs. So talk to the providers and figure out what's wrong.
Dr. Nina?
If I can, it's been well stated, the alignment piece, certainly if you're a provider and you have 12 different contracts with 12 different metrics, is very hard, and it doesn't pay to do all of them. So you look for your largest provider, maybe put your energy there. So if there's more alignment, certainly starting with the upside potential, and then I think showing them that the path to savings is through quality. And emphasizing the quality piece, I think, makes sense. But it's certainly a challenge and something that we have to just continue to think about, because I think there are opportunities to be had if we can work together with our providers. And interestingly, on that question about tracking effectiveness of high-risk care coordination, I was glad that member experience was included. The provider experience was at the bottom. And sometimes I think we forget providers at the table, and they need to be brought into the conversations as well.
Thank you. Now, before we close, I'd like to pose a question to our panelists that we always close with during our release event. If you have a magic crystal ball to predict the future, what do you think will be elevated in the report next year? Last year, we asked our speakers that questions, and they highlighted: number one, public health emergency unwinding and flexibilities, behavioral and maternal health crisis, members' access to care, and sharing power with community-based organizations. They said these were the areas we should keep our eyes on. And I think they were pretty spot on. So now I ask this year's reactant panel, what issues will take center stage over the coming year? What trends, issues, and developments do you think we'll be talking about next year? What is coming our way, positive or negative? Poppy, let's start with you.
Yeah, so I think I would really love to see kind of the thing I was just mentioning, this expansion of what is a provider, what is a Medicaid provider, and who can Medicaid pay. I think we've got a lot of, energy around different community health or SDOH issues that I think we need to be expansive on who we think we can pay to address those issues. And then secondly, I think workforce is going to continue to be a hot topic. Not just on the provider side, but I think at the health plans as well. I'm really curious to see how, the Great Resignation might be a trend that's over, but I think it still happens and is shuffling through the insurance industry. So I'm curious to see how health plan workforce is going to impact our ability to meet all these, many requirements that Medicaid MCOs are expected to meet.
Thank you. Dr. Nina?
Let's see. Well, a couple of things. I think as we continue to push and progress with value-based, to think about how we can add the appropriate metrics around health equity. I think that's important. And then the other thing, which is tangentially related, and I was having this conversation with our actuaries, is again, how do you develop an ROI on some of the SDOH and health equity initiatives so that you can capture that work even from the health plan perspective. And so I think we need to tease that out, and plans will be more strategic as we think about how to do more of that work. I guess those are the two things. And the other one is all related, is just building trust, so that the members are more engaged.
It's a very important one. And finally, and certainly not least, Lindsay.
Yeah, oh my gosh, I have so many thoughts. So I'll just try to pick a few. I think we're going to see a renewed focus on high cost treatments, high cost drugs, particularly as it intersects with efforts to reduce disparities. And I think some complex challenges to think through, for policymakers to think through, and plans to think through how to make those accessible to folks and navigate the costs of those treatments. I think health-related social needs, as Dr. Everett already said, going to continue to be a top focus, particularly as there are a new 1115 waiver opportunity in this space, and clarity from the federal government around in lieu of services and managed care. And then I think justice involved individuals and the role of health plans in working with states to support individuals transitioning out of criminal justice settings and into the community. I think that's probably going to be big in 2024 and 2025. So, and then of course, all the issues we talked about today are probably going to continue to be front and center, but I would just add those to the radar.
Thank you all for a great panel discussion. Let me turn things over to Jennifer Moore, who will wrap things up for us. Thank you.
Thank you, Gail. Thank you, panelists. Really appreciate this conversation and digging deeper into the Medicaid data that we collected through the survey, and sharing the different perspectives and thinking about what the data means, but what it means for the future also. And going back to Dr. Ige's remarks about what's next. How can we use this information to inform our next steps collectively and individually as we move forward? So thank you again. This is always the highlight of the release event, is this panel, and could not do it without you. Pretty soon, my colleagues are going to be dropping a brief link for a brief 2-minute feedback survey for you to complete. It's really helpful and important for us to have you complete this 2-minute survey. It helps us figure out how to improve our webinar offerings and experiences, but it also helps us to meet your needs as our Medicaid community. So please share that feedback with us. We certainly incorporate it into our webinars into the future. I'd also like to once again thank our survey subcommittee members and the IMI survey team who lead this important work. And then they do that by refining the survey instrument to collect salient information, analyzing the data and identifying effective ways to present it, and actively working with individuals and organizations who provide feedback and guidance to enhance the overall project. And everyone who's serving on the panel, including our moderator, actively provide us with feedback and guidance along the way too. And we want to extend that opportunity to you. If in hearing the presentation today or seeing the fact sheets, you think of a question or answer options that might be missing from our survey, we want to hear from you, and definitely send that to us because we certainly take every recommendation seriously and goes to the survey subcommittee for review and consideration. This is a community survey and we want everybody's voice in it. So finally, before we close today, I wanted to share that the recording of this webinar will be sent to you early next week, and you can access the survey findings using the link that's in the chat box. So with that, want to conclude today's survey event, and thank you again for joining us on a Friday afternoon.